Alright, this is a crash course on pancreatitis. Let me start my fucking stopwatch because some of us talk too much. And that some of us is me. I never learned how to stop talking. Okay, pancreatitis. This is a third semester topic, but there is some inclusion of fourth semester stuff. So this is great for exit HESI and also third semester and I guess NCLEX, because this is from Saunders, and Saunders cites Lewis. So I hope if I send this out to anyone, if I'm fucking brave enough to do that, other than for my own personal use, then it helps, because my objective is not to get famous on YouTube. I do not want people to know what I'm doing in my personal life. Oh my god. Okay, pancreatitis. So what is pancreatitis? Pancreatitis, as in, the suffix says itis, inflammation of the pancreas. So we are doing an attack on the pancreas, and the pancreas is technically an endocrine and GI organ because it has endocrine and exocrine functions. The endocrine functions being the production of insulin and glucagon, controlling our blood sugar levels, and the exocrine function being the digestive enzymes that are secreted into the GI tract, into the intestines to break down and digest our food. So what is the issue is we're actually bombing the pancreas like it is a terroristic threat, and in acute pancreatitis it happens suddenly. And what do we what happens when we bomb the shit out of the pancreas? Well, we're releasing all of the things that shouldn't be there, or that should be there, into places where they're not supposed to be, e.g. the digestive enzyme. They're being released into the rest of the body where they're not supposed to be. And at the same time, we've now stopped the production of insulin and the management of glucagon. So chronic pancreatitis, which I'll do later, but that is the continual inflammation. The acute pancreatitis is a sudden onset. And some precipitating factors I have here in red is alcohol. The use of alcohol will fuck up your liver, but it will also fuck up your pancreas. It's kind of like a Russian roulette to see which one happens first. Direct trauma, I guess if you got stabbed really bad, if you were just in the wrong neighborhood, I don't know. Biliary tract disease, viral or bacterial disease, hyperlipidemia, hypercalcemia, cholestasis, that's the gallstones, hyperparathyroidism, ischemic vascular disease, and peptic ulcer disease. The biggest one out of those is alcoholism. So how is acute pancreatitis gonna present? So if you can imagine that we just did a terrorist attack on our fucking pancreas, you're gonna for sure have some abdominal pain. It's worth mentioning, bring back your AMP here, the abdomen is an organ towards the back of the body. It's not at the front with the intestines and the stomach. It's towards the back. So you'll get some mid-epigastric pain, that kind of similar to heartburn. You'll get left upper quadrant pain, but it's going to radiate to the back because that's where the pancreas is. That's considered a retroperitoneal. It's in the back of the peritoneum. So, that back pain, which will be relevant later because, if I have back pain, why the fuck would I want to lay on my back? So don't make that patient lie on their back. That's a big no-no. You've just tortured the fuck out of a patient who got their pancreas bombed because they were an alcoholic. So the pain is aggravated by fatty meals, alcohol, of course, because they were, drinking themselves to death, or lying in a recumbent position. Recumbent meaning supine. We just talked about that shit hurt. That shit hurt a lot because it's in, the pancreas is in the back, so we're not going to lie on our back. Aggravated by fatty meals, most of the times they'll just say eating. You don't want to eat because eating stimulates the digestive enzymes produced by the pancreas that are supposed to break down the food we've just ingested. So it's like the action of eating and the early digestive process that occurs in the mouth and in the stomach is letting the pancreas know, hey, there's some food coming down to the lower GI. You got to start start producing some enzymes so we can, shit this stuff out. We can absorb what we need to and shit the rest. But, if we're in dysfunction and those enzymes are leaking out, we don't want to eat anything because eating is going to stimulate the release, and now we're just going to digest the rest of the fucking body like it's some sort of cannibalism. Of course, restless, anxiety, low-grade fever. By the way, anything that's in pink is like most RN relative, like something relevant, sorry. That's like the things you would see most on an exam. That's what you need to know for an action. Anything that is yellow is highlighting, like patho or AMP, something kind of like background knowledge, and green is an explanation. Okay, restlessness, anxiety, low-grade fever, that goes with, it can become a systemic infection. Abdominal tenderness, distension, guarding, that's fair. Nausea, vomiting, that's fair if you feel like ass. Weight loss, why would I eat if eating hurts? Again, with the autodigestion of the pancreas, of the other organs. So again, eating increases enzyme secretion, and that's gonna worsen how our body is doing. They're gonna, because it's an infection, they're gonna have elevated white blood cell count, or it's inflammatory disease, elevated white blood cell count, elevated glucose. Why? Because we're not producing insulin. So that's a good lab to look at. Glucose, it's going to be elevated. Bilirubin, alkaline phosphate, and urinary amylase levels. The detailed diagnostic that you will often see on your exams, it's a tall tale, is it tall tale? I think it's tall tale. Lipase and amylase levels. Why? Because these are specific digestive enzymes related to the pancreas. So commit that to memory. Lipase and amylase. You also have small amounts that are released in your saliva, but lipase and amylase for the pancreas. What else? Some other telltale signs, physical signs, are the Collins and the Turner signs. The Collins sign is that bruising around the umbilicus, the belly button. I fucking stole this from Miss Woodruff, who also uses Lewis Medical Surgical Nursing. That bruising around the umbilicus, like a C around the belly button, for Cullen's sign. Turner's sign is the bruising around the flanks, or like the waist, like the sides of the back, which she kind of, her mnemonic, her memorization tool is T for turn around, like turn your back. And then, again, there's an explanation here. The Collins sign is discoloration of the abdomen, and the periumbilical area. Turner's is the bluest discoloration of the flanks. The reason this happens, I hate that they don't explain the patho, is that, again, those digestive enzymes that are, cannibalizing the internal organs of your body include the blood vessels. And when you eat the fuck out of your blood vessels, the body's going to bleed. That bleeding is going to lead to that hematoma, to that bruising that you see around the umbilicus and the flank. Why? Because the pancreas is a retroperitoneal organ. That makes sense, right? Okay, what are we going to do as a nurse? First off, it's scary as shit. This is a very painful condition. So be aware of opiates. You're going to give opiates for pain for sure. It's going to be like hydromorphone or something. We're not going to give NSAIDs. So one of the things you have to prioritize is food and fluids. We talked about hypovolemia. I hope I mentioned that. Oh no, I mentioned it here. Okay, so hypovolemia. Why are they hypovolemic? Because pancreatitis triggers, or any major inflammation of the body triggers, something called SIRS, or systemic inflammatory response, which is again a systemic response. The body responds to major inflammation somewhere in the body, somewhere else in the body. That will do a kind of domino effect of increasing the permeability of the capillaries, and that will allow fluid to escape out of the blood vessels and into what we call third spacing, kind of the interstitial fluid, interstitial tissue, interstitial spaces where it's not supposed to be. So they will get edema, That's what third spacing is. The fluid leaves the blood vessels and goes into the interstitial tissue, interstitial space where it's not supposed to be. That is a presentation of edema. That's third spacing. And that causes hypovolemia because although the fluid is there, it's not in the blood vessels. So we need to, one, withhold food so we can stop the autodigestion and maintain hydrations via IV. It might be lactated ringers because they're going to have problems with their electrolytes because they're technically dehydrated. They don't have fluid where it's supposed to be. Administer parenteral nutrition, again, because they can't eat it orally. Supplemental preparations of vitamins. NG tube. I put a underline on that one because I specifically remember Miss Berkey stating it, but I haven't seen it as a major thing for UWorld. So a lot of the GI conditions, we'll put an NG tube to decompress the stomach, release and relieve of pressure. They're going to be NPO status. They may be for NPO for a while. And we may do a nasojejunal tube. That's kind of a redundant statement. Okay, and opioids for pain because it's hella painful. H2 receptor antagonists and proton pump inhibitors. I remember this specifically being stated by Miss Berkey. It hasn't yet been stated for UWorld, but it is definitely a Miss Berkey thing. Decrease the H2, the I don't remember what specific. What is it like? No, that's the fucking generic. The generic, it's like famotidine, and then the proton pump inhibitor is like Protonix, omeprazole. They'll decrease the stomach acid. That's what hydrochloric acid is, the stomach acid, so we don't, burn ourselves to death. And they'll prevent the activation of the pancreatic enzymes. You want to monitor those vital signs because this person can go into shock. Again, remember hypovolemia. You guys don't talk about shock until the last semester. Okay, yeah, the blood pressure can drop. And the definition of all the shocks, there's different types of shocks, is a severely life-threatening decreased blood pressure and hypovolemia. Or not necessarily hypovolemia. In this case, it's hypovolemia, but the definition of shock is a severely low blood pressure. What next? Changes in behavior. One of the things that could cause this change in behavior is alcohol withdrawal, but more than likely, you want to look at impending sepsis, impending shock, and hypoxia. Why are we going to get hypoxic? This is a more fourth semester kind of NCLEX HESI, exit HESI topic, but again, the systemic inflammation can lead to ARDS, which is another type of respiratory inflammation, which is fluid in the alveoli, increased capillary permeability in the respiratory tract, specifically around the alveoli, which can lead to scarring, which leads to I can't fucking breathe. They're going to become hypoxic. The major organs are going to suffer. We're going to have tissue ischemia, and it's one of the only, if not the only, the primary sign of ARDS is that no matter what kind of oxygen you give them, they're resistant. It doesn't get better. Anyways, back to pancreatitis. Avoid alcohol. I feel like they should, we should fucking know this by now. This person was drinking themselves to death at 2 p.m. on a Tuesday. They really need to stop doing that. And again, this one's acute. They can get better. They can have repeated insults. They can have repeated events that are fixed and then they go back to, especially if they do not resolve their alcoholism. We want them to report to their primary healthcare provider of the abdominal pain, jaundice, and clay-colored stools or dark urine, which is an indicator that this has returned, has gotten worse, or we're going to develop, some other biliary problems. Anyways, I am so fucking proud of myself for making it under 15 minutes. Holy shit, I hope that, oh my god, I stuttered. I hope that helps. I know it helps me to pretend that I'm teaching. Anyways, I'm done.